A very good evening, everyone. So we are back again, and this time we are up with the top topics targeting NEET PG, right? So basically, this session is targeting NEET PG and includes concept-based questions, image-based questions, previously asked questions, and some factual questions. So basically, these are the top topics from all of these and some anticipated questions, right? So I have kind of clubbed all of them, and we'll try to discuss them as much in detail as possible. All right. So basically, if everything is okay, if all is working well, uh, just give me a thumbs up. So, before we start the main session, let's discuss about the NEET PG vitals. So, when I talk of NEET PG vitals, these are basically the recorded videos, right? So, it has a detailed discussion spanning over 800 plus hours of recorded sessions, right? So, that is really helpful in all the preparations and revisions and elaborate and concise information at one place. So that is quite helpful if you are targeting NEET PG or next. And then also for the FMG aspirants, we have the All India Medical Test, right, which is a free 100% scholarship paper, which is for 25th of June. Then also for FMG aspirants, we have the test series. So this test series is exclusively available on the Unacademy store, and it is from 14th June to 30th July. Right, so it is at a minimal subscription, and you can use the code Bhumika if you want some added benefits. Also, we have the ACE Next or Next 23 or NEET PG 24 targeting, which are targeting these exams. These are the live discussions starting 21st June onwards. And then, last but not the least, FMG is also offering the FMGE Rapid Booster Batch. So we have a lot in the pool. You can pick and choose whichever suits best for you. Right, so I have the comments in the chat box. If all is working well, if audiovisual is okay, there's no glitch anywhere. So please give me a thumbs up so that we can start discussing. All right. Hello, Soumya, Tiny World, Roshni, Paritosh, Ugandar, and Swami. So we have a lot of people who've joined us. All right, so let's start. So the first thing to discuss here is this image. And as I always say, I do not like giving options because I want the level of preparation to that the threshold should be so high that you see the image and you know the answer. And that, again, as I said, that saves on your time, that saves on your mental energy. So some classical pictures, whenever I have some classical pictures, I will not give you options so that it comes out from your mind, it comes direct, and it saves on time. So now you have to tell me, what is this? What is this? So what do you see in the image? So what are we seeing in the image? So we have some skin lesions which are characteristically on one side of the face and is strictly following the vertical midline. Absolutely right. So what are we discussing? What are we talking about? So what we are talking about is this is an affection of herpes zoster, but this is called as herpes zoster ophthalmicus. Absolutely, which I had some answers from you. So this is not herpetic ophthalmicus. This is herpes zoster ophthalmicus. All right. So when we talk of this, what is herpes zoster ophthalmicus, or what is famously called as HZO? This is nothing, but please remember, this is the reinfection. It's not the primary but it is the reinfection. So it is the reinfection of Gazarian ganglion. It is the reinfection of Gazarian ganglion of, this is of for which nerve? This is for fifth nerve by herpes zoster virus. Also, it is famously called, when it occurs in adults, it is famously called as shingles. Right? So the important thing is it is a reinfection of fifth nerve by herpes zoster, and it is also called as, I think it has got hidden behind me, it is also called as shingles. So now, when we talk of herpes zoster ophthalmicus, so what are the presentations? Now you have to tell me the three basic presentations which you should know. Tell me. So, what are the three basic presentations that you should always know whenever we talk of herpes zoster ophthalmicus? What is shown in the image? What kind of presentation is shown in the image? Hutchinson's sign. Okay, so Hutchinson's sign is something which is one of the variants of the presentation of what we're going to discuss now. So, three basic things what it will present as is zoster dermatitis, zoster keratitis, and post-herpetic neuralgia. Okay, so these are the three things. So which out of this is shown in this image? Now you tell me which out of these three is shown in this image. What is shown? Is it dermatitis? Is it keratitis? Or is it post-herpetic neuralgia? What is shown in the image? So what we see in the image is actually dermatitis, which is the zoster dermatitis. So whenever we talk of a zoster dermatitis, please remember it has a dermatomal distribution. And it strictly is to the vertical midline. It strictly follows vertical midline. That is shown in the image. So it is a herpes zoster dermatitis. So if this question comes, so the correct option, the correct answer for this question which I asked you, identify this image, is it is a herpes zoster dermatitis. It is not ophthalmicus. The picture anywhere is not showing corneal involvement. So, right. So now you get that. The question that I asked was identify the image. So it is not herpes zoster ophthalmicus. This is basically herpes zoster dermatitis. Okay, so now you know it has a dermatomal distribution which is strictly limited, or which strictly follows the vertical midline. It strictly follows the vertical midline. Then we come to the second thing, which is zoster keratitis. So when we talk of zoster keratitis, now tell me, the important question is most common nerve involved is. Which is the most common nerve involved here in zoster keratitis? Tell me, this you should be able to answer. Which is the most common nerve involvement in zoster keratitis? Randoms, thank you for the compliment. But now you have to answer which is the most common nerve involved in zoster keratitis. Tell me. Seventh nerve. See, zoster, what we're already talking about the fifth nerve, right? So it is, okay. So this is basically the frontal branch. The frontal branch of the fifth nerve is the most commonly involved nerve. Number two that you should know about keratitis is what is the characteristic lesion? What is the characteristic stromal lesion of zoster keratitis? It is, so the most common nerve involved, frontal branch. Which is the characteristic stromal lesion of zoster keratitis is nummular corneal infiltrates. Okay, so the nummular stromal keratitis, nummular corneal infiltrates is the characteristic stromal lesion of zoster keratitis. Right? All right. And then the third important thing that you should know about zoster is zoster dermatitis, zoster keratitis, and the third is post-herpetic neuralgia. Post-herpetic neuralgia. And when this neuralgia is associated with anesthesia of the involved area, it is called as anesthesia dolorosa. Okay, so now whenever there's an image concerning herpes zoster, so whenever there's an ocular involvement, that is called as herpes zoster ophthalmicus. So the important points, let's revise. So when we talk of the important points of herpes zoster ophthalmicus, important thing is it is a reinfection of the Gazarian ganglion, which is for the fifth nerve, right? It is caused by herpes zoster virus and it is divided into dermatitis, keratitis, post-herpetic neuralgia. So whenever we talk of dermatitis, there is a strict dermatomal redistribution along the vertical midline. Keratitis, most common involved nerve is frontal branch. Characteristic stromal lesion is the nummular corneal infiltrates. Then you have a post-herpetic neuralgia, and if anesthesia associated, it is called as anesthesia dolorosa. Then another important question from this is, now identify this sign. So we just did keratitis. So one important thing is identify this sign. So if I give you this image, now what will you call it? Tell me. So the important things to see here is there is the skin lesion which is involving the forehead, which is following the strict vertical midline, and there is corneal involvement also. And third important thing to see in the image is involvement of the tip of the nose. So now which sign is this? Somebody had answered here above. Which sign is this now? Tell me. Now tell me which sign is this, and the other important thing that you have to tell me is which nerve is involved here. Tell me now. So this characteristically is telling you that it is associated with herpes zoster ophthalmicus. And which sign is this? Tell me, come on. Which sign is this? This is the, anyone? Yes, Vignesh. This is the Hutchinson's sign. I think you were trying to write Hutchinson, but something else has been written. So this is the Hutchinson sign. And when we talk of Hutchinson's sign, which nerve is involved? Which nerve are we talking of when we talk of the Hutchinson's sign? So first, let's try and understand what is Hutchinson's sign. Hutchinson's sign is nothing, but it says whenever there is involvement of the tip of the nose or the ella of the nose, there is a high probability of having keratitis. Do you get it? So involvement of the tip or the ella of the nose has a higher probability of involvement of cornea, a higher probability of involvement of cornea. Now the question here is why? What is Hutchinson's sign based on? Yes, absolutely, Vignesh. Very good. The nerve which is involved here is the nasociliary nerve. So now you have to remember two things. The most commonly involved nerve, as we just discussed here, is not nasociliary, is the frontal branch. But Hutchinson's sign is based on nasociliary nerve. Why? Because it is the nasociliary nerve which supplies the tip of the nose, the ala of the nose, and the cornea. So whenever there is involvement of the tip of the nose or the ala of the nose, that means there is involvement of the nasociliary nerve, and now there is a high probability of involvement of cornea. Is that thing clear now? If it is clear, give me a thumbs up and then we move forward. So is it clear? Herpes zoster ophthalmicus. And second important thing when we talk of keratitis in herpes zoster ophthalmicus, please remember it gives you pseudodendrites. It gives you pseudodendrites, right? And where do you get dendrites? Tell me, which disease do you get dendrites? Dendritic lesions? Which lesion do you get? Which condition do you get dendritic lesions? Tell me. So let's see this. So when we talk of these two conditions, we talk of dendrite and we talk of pseudodendrite. So we know when we talk of dendritic lesions, these are the amoeboid lesions which have these terminal bulbs. These are these lesions which have the terminal bulbs. These are the lesions with amoeboid configuration with terminal bulbs, whereas pseudodendrites are the lesions which lack terminal bulbs. They lack terminal bulbs. So which condition do you get dendritic lesions? Dendritic is seen in herpes simplex virus lesions, whereas pseudodendrites are seen in herpes zoster virus lesions. So when we talk of pseudodendrites are comparatively smaller. They are peripheral in location and they lack terminal bulbs. So pseudodendrites are seen in herpes zoster, whereas true dendritic lesions which have terminal bulbs are seen in cases of herpes simplex. Is that clear? So now we all know acanthamoeba keratitis, no Campylobacter. Acanthamoeba keratitis gives you what kind of lesions? Acanthamoeba keratitis gives you ring infiltrates. It gives you ring infiltrates and it has classical radial perineuritis or keratoneuritis. Okay, so that is what you get in acanthamoeba. All right, so we come to the next question. The next question talks about a mother brings her 8 months old baby. So that means an infant to the clinic with complaints of epiphora, photophobia, and blepharospasm. On examination, you find corneal edema, okay, corneal edema and opacified cornea in the left eye. So that means we are dealing with, what does that mean? We are dealing with a bilateral disease. Okay, so EUA is planned owing to enlarged corneal diameters. The procedure depicted in the image would show all of the following except. So before we come to the answer, you have to tell me what are we dealing with. So basically, when I see the question again, so we have an infant who is less than 1 year of age presenting with epiphora, photophobia and blepharospasm with corneal edema in the right eye and opacified cornea in the left eye with enlarged corneal diameters. So what is the diagnosis? So my first question is, what is the diagnosis? Tell me. What are we dealing with? Then we would come to the question. So tell me, what is the diagnosis? This is what? Even if you do not see the image, even if you do not know what's happening, just read the question and tell me, what are we dealing? Yes, Vignesh, we are dealing with primary congenital glaucoma. So what are we dealing with? We are dealing with primary, which is PCG. We are dealing with primary congenital glaucoma. Okay, so now the question asks you, what is the procedure depicted in the image? Tell me, what procedure is being shown in the image? So you see here, there's an image. What is depicted in the image? There's something here which is placed. So what procedure is being done? Tell me. What procedure is being done here? So you know it is EUA, it is examination under anesthesia. And what we are doing here is we are doing gonioscopy. So what is being done here? We are doing gonioscopy. And we are doing with which lens? Now you have to tell me which lens is being used. See, one image can teach you so much. So which lens is used here? This process, this procedure, gonioscopy, is being done under examination under anesthesia, which is EUA, using which lens? Tell me, which lens is this being used here? Which lens is being used here? So this is the Coipes lens. This is the Coipes lens. And I will tell you here, I have a special class, 1 hour free special class, which is already there on the Unacademy app on gonioscopy. So I have discussed in detail what is direct gonioscopy, what is indirect gonioscopy. So I will write it down here so that you have with you. So there's a class on, there's a free special class on gonioscopy, which is very, very important. There was recently a question on direct gonioscopic lenses. So it is a free special class which is already recorded on an Academy app. So you should listen to that lecture. That's an interesting class, and you always have so many questions on gonioscopy. So coming back to this, this is a Coipes lens, a direct gonioscopic lens, which is being used here in the supine position in the child to view the angle which is being viewed for primary congenital glaucoma. Okay, is that clear? So now what are we trying to ask you is, what are the gonioscopic findings of primary congenital glaucoma? Now you tell me what is the answer. Barkin's membrane, Lister's morning mist, widening of the CBB, that is the ciliary body band, or Loch Ness monster phenomena. What is the thing that you would not find on gonioscopy? So it would show all of the following except any answers. Anybody who wants to attempt this? Anyone who wants to attempt? All right. So I will tell you, when we talk of widening of the ciliary body band, where do you get this? So widening of the ciliary body band is seen in angle recession. Is seen in angle recession, which is seen in trauma. So, angle recession is one of the causes of glaucoma in trauma. And in that angle recession, the gonioscopic finding is widening of the ciliary body band. So, you have Barkin's membrane, Lister's morning mist, and Loch Ness monster phenomena, which is seen in gonioscopic findings of primary congenital glaucoma. And I have discussed in detail about what are these appearances, what are these in my recorded sessions in my courses on the Unacademy app. All right, so you can go through them, you can learn through it, right? So now let's quickly see what is primary congenital glaucoma. So when you talk of primary congenital glaucoma, please remember it is a bilateral disease. An important thing to remember is 80% of the children 80% of the children are diagnosed before their first birthday. Before the first birthday. That means less than 1 year of age, you get to know about the disease. So, what are the indications? What is the etiopathogenesis? The etiopathogenesis here is, what is the etiopathogenesis of primary congenital glaucoma? It is angle dysgenesis or trabeculo dysgenesis with anterior insertion of iris, right? So this is primary congenital glaucoma, which is bilateral disease. 80% of this condition is diagnosed within first year of life, as has been discussed in this question also. And the etiopathogenesis, there's trabecular dysgenesis with anterior insertion of the iris. And what is the classical clinical triad? The classical clinical triad is, as I always say, the mnemonic to remember is pebble. It is. So the answer is photophobia, epiphora, and blepharospasm. Okay. Is that clear? So the mnemonic to remember, the classical clinical triad is pebble. The pebble, we have photophobia, epiphora, and blepharospasm. So this is the classical clinical triad, which has again been asked in the question. There is epiphora, there is photophobia, and there is blepharospasm. And what is the presentation of a primary congenital glaucoma like? So what you get is what is exactly what is asked in the question is there is enlarged corneal diameter. So primary congenital glaucoma basically means the damage to the entire globe in pediatric cases. As we vis-a-vis in adults, when we talk of the glaucoma in adults, it is basically the damage to the optic nerve head because of the raised intraocular pressure. But in pediatric cases, it is the damage to the entire globe. Why? Because till 4 years of age, the globe can expand. Right? So what do you get? Once the globe expands, when the eye is enlarging because of raised intraocular pressure, so what we get is the enlarged corneal diameter. So let's see how can they present with as they can have enlarged corneal diameter as is shown here. The other thing that you can have is, what do you see in the image B? This is image B. What do you get to see? Please see carefully. What are we seeing here? So what is the difference between the two images? You see a red glow here in the posterior part, as if the red glow is coming from behind. So what kind of a slit lamp illumination method is being used in this one? In this image, what kind of a slit lamp evaluation technique is being used? This is called as retro illumination. Okay, so you view this on retro illumination. And what is image B? Tell me, what do you get to see in image B? So what we get to see is these are the opaque lines with double contour. And tell me, what are these lines called? So you get to see these lines because of raised intraocular pressure and its effect on the globe. And what are these lines called? What is the name of these lines? Tell me. Tell me in the chat box. Tell me. Okay, I'm waiting. So you have to tell me what are these lines, the opaque lines with double contour called? These are called as Habs striae. These are called as hamstria. And last but not the least, what you get is what you see in image C. So what is this? This is the opacified cornea. So what you get to see, you see a corneal edema and hence opacification of the cornea. So corneal edema or corneal opacification is probably the first sign in children less than 3 months of age. Okay, so these are how can they present with. And then what are the gonioscopic findings? I told you it is Lister's morning mist, Barkan's membrane, and Loch Ness monster phenomenon. So primary congenital glaucoma, again, so this is the second topic which you must know, must know, is primary congenital glaucoma. The first that we discussed was viral keratitis. So I will keep writing here so that you know all these important topics. So viral keratitis is one, primary congenital glaucoma, developmental glaucoma is second. Then we come to the third question. A class of anti-glaucoma medications which is the latest approved entry, and acts on the conventional trabecular meshwork is. So here the third important topic that comes to our mind is the anti-glaucoma drugs. The anti-glaucoma drugs. So now tell me what is the answer. Tell me the answer. So a class of anti-glaucoma medication number. So here there are two catch points. So one thing is it should be the latest approved entry and acting on the conventional trabecular meshwork. So tell me the answer. Anybody who wants to attempt? All right, Vignesh, I take that nitarsudil, but you have to tell me which class does it belong to out of these options. So which class does it belong to? Is it prostaglandin analog, Rho kinase inhibitors, beta adrenergic antagonist, or what is called beta blockers, or the hyperosmotic agents? Tell me. So anyone else who wants to attempt? He says, Vignesh says B. Anybody else who wants to attempt? You're right. So the answer here is absolutely Rho kinase inhibitors. Now you tell me which are the two Rho kinase inhibitors which are being used. So the two Rho kinase inhibitors being used are one, Vignesh has already said, nitarsudil. Which is the other one? Tell me. The other one is? So which are the drugs which are included in Rho kinase inhibitors? So please remember, Rho kinase inhibitors are the latest entry to the anti-glaucoma medications. And the two drugs which are involved in Rho kinase inhibitors is ripasudil and nitarsudil. Ripasudil and nitarsudil. And the other important thing to remember, so the second part of the question was with the ones which act on congenital trabecular meshwork. So the answer here is the drugs which act on the conventional trabecular meshwork are. So which are the drugs which act on the trabecular meshwork? They are one, the Rho kinase inhibitors, and you have to tell me the second option. The second ones are tell me the second class of anti-glaucoma medications which act on the trabecular meshwork is miotics or parasympathomimetics. Okay, so miotics are the second class of drugs that which includes pilocarpine, which acts on the trabecular meshwork. Rest all of the drugs, they are either the aqueous suppressants or they act on the uveoscleral meshwork. Okay, so we have two kind of questions here. The ones which are the latest entry, these two drugs have been have been approved for the use in USA and Japan. And number two, which are the two drugs which are used, ripasudil, natarsudil, and the drugs which act on the trabecular meshwork are rho kinase inhibitors and the miotics. So the third important topic to remember is anti-glaucoma medications and their side effects. All right, so next we come to this question. A 70-year-old man reports for cataract surgery. He reports for cataract surgery. On further evaluation, you note a poorly dilating pupil with grayish pigment deposition on the anterior surface of the lens and phacodonesis, along with raised intraocular pressure. So the most common cause of secondary open angle glaucoma is, so my aim here is to give you the maximum. So I put in all the type of questions which can be asked. So here there are two questions which have been clubbed together. So one question is, what is the most common cause of secondary open angle glaucoma? So this is one and this is two. So the first is the clinical scenario and second is a fact which has been clubbed together. So here you have to remember that the question talks about an old man presenting to you with poorly dilating pupil with grayish pigment deposition on the anterior surface of the lens with phacodonesis and raised intraocular pressure. So what is the cause? Tell me. What is the cause? What is the answer here? What is the diagnosis? Also, this answer is the most common cause of secondary open angle glaucoma. Tell me. Very good, Ramya. Very good, Rohit. So the answer here is PEX. It is also called as pseudo-exfoliative glaucoma, pseudo-exfoliative syndrome, or pseudo-exfoliative PEX, pseudo-exfoliative syndrome. Right? And whenever we talk of PEX, please remember, let's discuss. So whenever we talk of PEX, pseudo-exfoliative glaucoma, pseudo-exfoliation. So what you have to remember is it is the most common cause of secondary open angle glaucoma. It is age-related, classically seen in more than 70 years of age. So what you have is a grayish pigment deposition on all the structures from anterior to posterior. You will have it on the cornea, you will have it on the pupil, you will have it in the angle, more so inferiorly on the anterior surface of the lens, on the zonules, on the anterior hyaloid. And when we talk of lens, what is the classical pattern that we get when there is a pigment deposition on the lens? What do we call it? Tell me. Very good, Ramya. We call it as bull's eye pattern. We call it as bull's eye pattern. And another important thing is, what is the gonioscopic finding that you get in PEX? Tell me quickly. So what do you get in a gonioscope? What you get is a Sampiolacy line. So what is Sampiolacy line? Sampiolacy line is pigment deposition anterior to the Schwall-Base line. You have a poorly dilating pupil and you have a raised intraocular pressure. Though Sampiolacy line is not pathognomic, please note it is not pathognomic of PEX, right? So PEX is pseudo-exfoliative syndrome, most common cause of secondary open angle glaucoma, also the most common cause of acquired zonular insufficiency. Okay, so this is PEX, pseudo exfoliation or pseudo exfoliative syndrome. So now we come to what is the important topic that you must know. We are talking about secondary glaucomas. We are talking about secondary glaucomas. By secondary glaucomas include your lens-induced glaucomas, your pigment dispersion syndrome, pseudo-exfoliative syndrome, steroid-induced glaucomas, and trauma and glaucoma. Then you have your all these uveitis associated glaucomas, right? So that is PEX. All right. So now we move on to a 60-year-old female. All right. So now we talk of a 60-year-old female underwent a complicated cataract surgery, and after a week of surgery, BCA was 6.9. But 3 months later, she reports back with painless, progressive, diminution of vision, and now her BCVA, that is best corrected visual acuity, is 6/60. So what does that mean? Her best corrected visual acuity was good post-op despite a complicated surgery, but now months later there is decrease in the vision. On examination, PCIOL was clear. Why has this been mentioned? What do you mean by PCIOL was clear and in the bag with a ruptured posterior capsule? And posterior segment evaluation showed the following picture. The provisional diagnosis is. So let's see what the question is talking about. So the question is talking about a delayed diminution, which is painless, which is progressive. So a patient who underwent a cataract surgery had a good gain of vision, but after a period of time had a painless progressive diminution of vision. So what is the common causes of painless progressive diminution of vision post cataract surgery? Tell me, what could be the causes? All right, so everyone says answer is C, but we are not here to come to the answer or the conclusion immediately. We need to know what are the other possibilities. So because it's just not this question which we want to crack, we want to crack any other question which is coming from the related topics. So it could either be a posterior capsular opacification or it could be a Irwin gas syndrome. So what is Irwin gas syndrome? Tell me. So what you're seeing in the picture, let's see the images first. So if you see in the image A, let's see the image A, this is B and this is C. So when we see in the image A, we see the foveal reflex is dull. And if we see, so which investigation is this shown in image B? Which investigation is shown in image B? Tell me. I told you, we're here to learn the maximum from these questions. Tell me. Which investigation is image B? Very good, Ramya. It is FA, or it is fundus fluorescein angiography, right? So this is B. And what is image shown in C? Which investigation is image C? Tell me, which investigation is image C? Good, Lavanya. So image A is the fundus colored fundus photograph. Image B is actually the fundus fluorescein angiographic picture of the same patient. And very good, Ramya. Okay, Vignesh, I'll conduct free classes. I'll come more. This time I'm coming more frequently. So I have another, this is one session one. And the session two, like the same NEET PG top topics, will be on Friday this time. So that is probably either 4 to 5. It is as of now planned on 4 to 5. It might be 6 to 7. I will give the confirmation on the Telegram group soon. So you all know I have a Telegram group which is by the name of Dr. Bhumika I. So I keep updating everything, and even for this session, the PDF will be uploaded on the Telegram group. So whatever information I have about the timings for the same session 2 of NEET PG top topics will be communicated on that group. All right. So now coming back to the question, we had Ramya, who said absolutely right. This is the OCT image. So let's see what when we collaborate the three images, what do we get? So when we see image A, we have a dull foveal reflex. And when we come to image B, which is the fundus fluorescein image of the same patient, it gives you a classical picture like this, which is like the petals of a flower. And this is called as a flower petaloid appearance, right? And the third image is OCT, where you get to see all these black spaces, which is the edema, the cystic spaces in the retinal layers. So whenever I have discussed these topics in my courses, I have explained why all this happens, but here it is difficult because of the shortage of time. So I have discussed in detail, why do we get a flower petaloid appearance, why do we get edema, and which layers do we get it. All right, so basically you have a dull foveal reflex, you have a flower petaloid appearance on FA, and you get these intraretinal cystic spaces on OCT. And what are we dealing with? So we are dealing with pseudophakic cystoid macular edema. So what are we dealing with? We are dealing with pseudophakic cystoid macular edema. We are dealing with pseudophakic cystoid macular edema. It is famously called as, once it occurs after cystoid macular edema, once it occurs after the cataract surgery, it is famously called as Irving gas syndrome. It is famously called as Irving gas syndrome. And when we talk of FA, what we get is a flower petaloid appearance. And this is because of the changes or because of the edema in the Henle's there. So this is pseudophakic CME, which is also called as the Irving gas syndrome. So this is a very common cause of reduced vision after certain amount of time post cataract surgery. Yes, Kiran, the cystoid macular edema, which is specifically after cataract surgery. Cystoid macular edema can occur anytime after surgery or even without surgery in uveitis patients, in posterior uveitis patients. But there we do not call it as Irving gas syndrome. So once you get a cystoid macular edema after the cataract surgery, that is the specific time when we call it as Irving gas syndrome. Okay. All right. So then here exactly what we have seen. This is what you get is the flower petaloid appearance. This is the common cause of reduced vision months after surgery. So this we have done. This is called as the Irving gas syndrome. And on FA, what you get is a flower petaloid appearance, and we have OCT. So let's see some more images. What is this? When you have an image something like this, and this area which is called as you see here, it is a beaten bronze appearance. So which disease do you get to see a beaten bronze appearance? So beaten bronze appearance is seen in, tell me, beaten bronze appearance is seen in which disease? Very good, Ash. It is seen in Stargardt's disease. Then we have an egg yolk appearance. So here I have drawn an egg yolk. Here what you see is an egg yolk, and it absolutely feels like this egg yolk has been placed on the retina. And which condition do you get? An egg yolk appearance. So egg yolk appearance is seen in, absolutely very good, Ash and Kiran. It is seen in cases of Best's disease, or it is called as vitelliform dystrophy or Best vitelliform dystrophy. So last we have this. What is this? So the hint here is there is a medication which is being used which results in the this kind of a pattern which resembles the eye of an animal. So what is this called? This is called as, it resembles the eye of an animal. And which medication leads to this? Tell me now. What kind of a picture is this? This is called as bull's eye maculopathy, and it is seen in, absolutely right, Ash and Vignesh, it is seen in chloroquine and hydroxychloroquine. So what is it? This is a bull's eye maculopathy, and we just read bull's eye pattern on the lens that is seen in cases of pseudo exfoliation syndrome. So bull's eye maculopathy is seen in chloroquine and hydroxychloroquine toxicity. Right? Is that clear? So now what you get to see in retina, what you have is all these pseudophakic cystoid macular edemas, the foveal diseases and the macular diseases, especially their names, what is the basic pathogenesis, and their images is important. All right. So now we come to, this is very easy. It's just to, quickly, let you know about the image pattern and the disease. So you have to tell me, you have to match the following. So what is A? Now you have to tell me what is A. So I will number these images as 1, 2, 3, and 4. Okay, I'll move a bit so that you can see the image 4 also. So now you have to tell me. This is easy. Okay, so Ramya asks me how to differentiate it with CRAO. Okay, that's a nice question. See, when I talk of CRAO, this is central retinal artery occlusion. So artery occlusion will also give you a pale retina. There will be edematous retina. Here the retina, if you see clearly, the retina is completely healthy. There's nothing wrong with the background. See, the retina is completely healthy. But when we talk of a CRAO, what you have is, you would have a pale opaque retina which is edematous, and then there would be a red spot in the center which is cherry red spot. So cherry red spot would be if it is red with a pale retina in the background, or an edematous retina in the background. And yes, there will be, the question will talk about a history, but that is altogether a different picture. I will keep that in mind, and I will show you that image of CRO and compare it with this image in the next session. Okay, all right, as of now you have to tell me, what is image mature cataract. Which image out of 1, 2, 3, 4 is mature cataract? Tell me. Which image out of the 4 is mature cataract? So A, mature, you feel it is 2. Okay, C. And now I will tell you. So how does the cataract progresses? So let's quickly brief up the cataract story here. So cataract is basically the opacification of the lens fibers, right? So we begin with immature senile cataract, which is the beginning part, where you have where the presentation can be in the form of the nuclear sclerosis, it can be in the formation of cortical cataract, or it can be posterior subcapsular cataract. So slowly and steadily, this opacification completely engulfs the entire cortex. So when the entire cortex becomes opacified, it is called as the mature cataract. So let's see, when I talk of immature senile cataract, I told you there are few opacities in the transparency of the lens. So now what you would see is the lens is transparent. So out of all the 4 images, where can you see the retro glow, the retro illumination, where the lens can be transparent? See in image 2, you have the red glow as we just saw in Habs stria, and then you see a small opacification here. So clearly that says this is immature senile cataract. So immature senile cataract can be of 3 types. It can be nuclear sclerosis, it can be cortical cataract, or it can be posterior subcapsular cataract. So here in the options, which is the immature senile cataract given in the options? Tell me. Yes, so the options given here is C. So C corresponds to image number 2. So now you get it why this is immature senile cataract, because there are certain fibers which are transparent with few opacities in the lens. So that is immature senile cataract. Number 2, I told you, when the entire lens cortex opacifies, it is called as mature, and that time what you get is a pearly white cataract. That is the mature cataract. So now you come down to the answer, which out of all is the mature cataract, which is pearly white in color and shown in the image. So now pearly white is either seen here in image 1 or in image 4. So now we come down to 2. So now what happens is, from this process, let's still be in this balance between 1 and 4. So now the story proceeds further that in mature cataract, there is the liquefaction process which begins. So once the process of liquefaction begins, the cortex starts becoming liquefied. But the nucleus which is present in the lens is still heavy. It is brown. It is undergoing sclerosis. So it tends to settle down. So when this happens, it is called as a hypermature cataract, which is the type of 2 types further. It can be sclerotic or Morgagnian. So when you have a liquefied cortex with the nucleus settled down like a sunset, this is called as a Morgagnian cataract. So D is image number 1, and this automatically image 4 becomes the mature cataract. And the other type of hypermature cataract is hypermature sclerotic cataract, where what you get to see is, if you see in this image, basically the liquefied cortex tends to escape from the anterior lens capsule. So once it escapes from the anterior lens capsule, what you get is, you get the convoluted or the corrugated surface. You have a corrugated surface with, you see these white dots here? These are with the calcific deposits. And this is called as hypermature sclerotic cataract. So this is image 3. So now are all the doubts clear about this? Are we clear about this? So we have immature senile cataract progressing to mature senile cataract, going to Morgagnian or a hypermature senile. So hypermature senile sclerotic cataract will have a corrugated surface with calcific specks, with calcific deposits. Right? So these are the types of cataracts and you should know it. Now, this is the last question of the day. What are these lenses used for? What are these lenses? Identify. What are these lenses? So these are 2 types of lenses which are used in which kind of a procedure? Tell me. Yes, these are used for gonioscopy. Very important. They are used for gonioscopy. So now I told you there are 2 types of methods. There's a direct gonioscopy and there's an indirect gonioscopy. So these 2 lenses are used for which kind of gonioscopy? Direct or indirect? The image that we just saw while discussing the primary congenital glaucoma, the lens that was being used, the patient was lying supine, the lens placed on the eye was direct gonioscopy. But here, when these lenses are used, what kind of lenses are these? These are for the indirect gonioscopy. So these lenses are used for indirect gonioscopy. And when we talk of indirect gonioscopy, the lenses that are used here, the lenses that are used in indirect gonioscopy are called as gonioprisms. And these gonioprisms can be of the scleral type or the corneal type. So now coming specifically to this question, so we have shown scleral type gonioprisms in this question, right? So what is the difference between these two images, image A and image B? So image A is basically a scleral type gonioprism, which is a single mirror. So this is a Goldman single mirror lens, and this one is a Goldman three mirror lens or three mirror gonio prism. Why three mirrors? So this is one, this is two, and this is three. So the next question which is asked is, what is the angulation of the mirror in this one? So what is the angulation of the mirror in this image A? The angulation used in this is 62 degrees, and in image B, out of the three, which lens is used for gonioscopy? It is the smallest mirror. It is the smallest mirror which is used for gonioscopy. These two are used for peripheral fundus evaluation. And then the question comes, what is the angulation of the mirror which is used for gonioscopy? The angulation of the mirror used for gonioscopy is 59 degrees. Is 59 degrees. So now the next important topic, as I said, is gonioscopy. So gonioscopy, the gonio lenses, the name of the gonio lenses, the types of the gonio prisms, what is the angulation which is used, what are they used for, what is indentation gonioscopy, what is manipulation gonioscopy. All this is important, and I told you there is a lecture on gonioscopy which you must listen to, right? So that is it for today. That is it for this session. So now we meet on Friday for the NEET PG top topics session number 2, which is again a 1-hour session, which currently is for 4 to 5 p.m. And if there's any change, I will update you on the Telegram group. Right? So if there are no queries, if there are no questions, I'll sign off. Please let me know if there are any questions or if you have any doubts. I'm happy to clarify. So if any doubts, please let me know. Otherwise, I'll sign off. Any queries, any questions? If nothing, please give me a thumbs up. Naira Sheikh, thank you so much. All right. So I think that is it for the day. So I'll just sign off. Take care. Good day.